Good morning, everyone. Thank you for joining me at today's session. For those that don't know me, my name is Laura Hanson and I'm an Associate Solicitor in the ASB team. Today we're going to be covering substance misuse and mental health, which is often referred to as dual diagnosis. By way of an overview, we'll be looking at what is dual diagnosis, the relationship between substance misuse and mental health, why dual diagnosis is problematic, case studies, and some practical tips using the NICE guidelines. If you have any questions on anything mentioned or require any further information, I'll put my contact details at the end of the presentation, so please feel free to contact me. You'll see from the slide a few of the most recent headlines in relation to mental health and substance misuse. As you can see, it is very topical at the moment. So on the 4th of February, a 40-year-old man with a long history of substance misuse and mental health problems was found dead in his Penrith flat. On the 30th of January, the likelihood of substance use disorders is almost twice as high among individuals with ADHD and 4 times as high among those with ADHD and conduct disorder. Young people with a history of mental health and drink and drug issues are more likely to die than those with mental health illness or those who use substances alone. And finally, an ex-police chief who led a damning review into mental health services in Tayside has been appointed to lead the Scottish Government's flagship drug deaths task force. He will have observed the lack of cooperation between mental health and substance misuse services closely, and that will stand him in good stead as this remains a national priority. On the 6th of December 2021, the government published From Harm to Hope, which they say is a 10-year plan for real change with an ambition to reduce overall use towards a historic 30-year low. Commitments are made across government to break drug supply chains while simultaneously reducing demand for drugs and getting people suffering from addiction into treatment and deterring recreational drug use. In addition, they say this will help us to level up by stopping the cycle of crime driven by addiction, keeping violence out of neighbourhoods across the country and saving lives through reducing the number of drug-related deaths and homicides. Disappointingly, despite this being a 65-page document with a 10-year strategy, there appears to be very little said in relation to dual diagnosis. So, first of all, what is meant by dual diagnosis? The term dual diagnosis is used in a variety of ways by people working in health and social care in the UK. In the NHS, it usually refers to the occurrence of a mental illness alongside substance misuse. However, it is not straightforward and the label is often seen as problematic. It is often a catch-22 situation, or what came first, the chicken or the egg. Another problem is that some studies have used the term to refer to any coexisting mental health illness, whereas others have restricted it to severe mental health illness only. The interplay between substance misuse and mental health is complex and can change over time. It can vary between people and it may depend on the type of mental health problem and on the type of and amount of substance misused. The Dual Diagnosis Good Practice Guide from the Department of Health describes 4 possible relationships between substance misuse and mental health. Number 1, a primary psychiatric illness causing or leading to substance misuse. Number 2, use of substances makes the mental health problem worse or alters its course. Number 3, intoxication and/or substance dependence leads to psychological symptoms. And number 4, substance misuse and/or withdrawal leads to psychiatric symptoms or illnesses. There are a range of factors that may make some people more vulnerable to either or both problems. These include genetic makeup, environment, and behaviour. The triggers are also diverse and may include a range of adverse life events such as homelessness, relationship breakdown, or bereavement. Adults and young people who have a severe mental health illness and misuse substances are among the most vulnerable in our society. Dual diagnosis is one of the biggest challenges facing frontline mental health services. The complexity of issues makes diagnosis, care and treatment more difficult. There is often a higher risk of relapse, readmission to hospital and suicide. In addition, there are a number of agencies involved, meaning care can be fragmented and people can fall through the cracks. Those with dual diagnosis have significantly poorer outcomes than people who have either serious mental health or substance misuse alone. Those who receive treatment from secondary care mental health services may be in contact with several services, including substance misuse, primary and secondary health care, social care, local authorities, housing and employment services. Communication between these services is absolutely key. It is also worth noting that some services may find it difficult to engage with coexisting severe mental health, illness, and substance misuse, and this can lead to people missing appointments, and so the cycle continues. I've noted on screen some of the services that may be involved in someone's care package. It would be worth familiarising yourself with the services available in your area, as good relationships with these services are going to help in your role too. So, a case study that I've recently dealt with. In this case, the tenancy commenced in November 2017. The antisocial behaviour started straight away in the form of noise nuisance, verbal altercations with people at the property, verbal altercations with neighbours, threats being made to neighbours, physical assault on neighbours, and a history of alcohol-related offences. The tenant had a dual diagnosis of severe anxiety and alcohol dependency. The housing provider attempted to address the ASB by adopting a number of non-legal interventions, such as warning letters, verbal warnings, telephone conversations, and home visits. However, these were unsuccessful, so the housing provider was forced to take legal action and sought an injunction to try and control the behaviour. At the hearing, an undertaking was agreed. The housing provider attempted to address the anxiety and alcoholism by making referrals to their internal support and wellbeing team. The support and wellbeing team then liaised with social services. Social services were able to arrange support from Change, Grow, Live, which is the local substance misuse organisation, and also Women Matter, which is a help and support organisation for women involved in the criminal justice system. But despite those interventions, the behaviour continued. This highlights the problematic and vicious cycle nature of a dual diagnosis. At times when the tenant was drinking heavily and not engaging in support, then the ASB worsened, and so on. As a housing provider who had attempted to address the ASB with non-legal interventions, attempted to address the mental health and alcoholism, and had already attempted injunction proceedings, they were left with no alternative but to commence possession proceedings. The defendant instructed solicitors to defend the proceedings, and the instruction of a consultant psychiatrist was agreed. The psych report revealed that the tenant had a very unhappy childhood with emotional, physical, and sexual abuse, and as a result went into foster care. The tenant had been significantly affected by their childhood. They lived on the streets and had no stable home environment. In addition, they had suffered an abusive relationship with their father. Unsurprisingly, the tenant turned to alcohol. They started drinking at 13 years old and drank heavily until 20. Then further life circumstances impacted, and the tenant returned to alcohol and drinking heavily due to domestic violence in a relationship, and was consuming in excess of 100 units of alcohol per week, when the recommended is actually only 14 units. The tenant reported that as of October 2021, she had involvement with the community alcohol team, Change, Grow, Live, and had been so for the previous 4 years, and had now reduced her intake to 25 units per week. In relation to the tenant's mental health, from the age of 18 onwards, they suffered from increasing mood disturbance, tearfulness, irritability, and difficulties with managing anger. They were diagnosed with depression and anxiety. They had also attempted to take an overdose on 4 occasions in an attempt to end their life. The tenant reported anxiety symptoms, which included gastrointestinal disturbance, palpitations, struggling to leave the house, fearfulness, and nausea. They were prescribed the antidepressant fluoxetine for the anxiety and depression and a beta blocker for the acute anxiety. This highlights the catch-22 situation the tenant finds themselves in. The social issues trigger their severe anxiety, which then leads to excessive drinking. As a result of this, they then fail to comply with any medical advice. The expert found that the alcohol was causing a lot of restlessness, anxiety, palpitations, high blood pressure, and sleeping problems. The tenant seems to try and cut down, but then starts drinking heavily again. In relation to their mental health recovery, the psychiatrist found that this would be heavily dependent upon their commitment to maintaining abstinence from alcohol. Again, engagement is key. In order to assist the mental health recovery, the tenant must remain fully compliant with the prescribed psychotropic medication and engage with any available therapy or counselling provided by the community alcohol team. If there is a further period of alcohol dependence, then a detoxification programme at an inpatient substance misuse unit would be appropriate. Given the history of sexual abuse, the tenant might also benefit from engagement with structured psychological therapy, such as trauma-focused cognitive behavioural therapy or eye movement desensitisation and reprocessing. This case shows the impact of substance misuse and mental health on antisocial behaviour. In the expert's opinion, the alleged conduct in this case was partially attributable to their disability, the severe anxiety. However, the alcohol dependence also had a significant impact upon their mood, anxiety symptoms, and overall mental state. In this case, we managed to agree a stringently worded SPR whereby the tenant must comply with the terms of the tenancy agreement, but we also included some specific recordings, which are actually the recommendations of the consultant psychiatrist, whereby the tenant agrees to continue to engage with Change, Grow, Live and Women Matter. They continue to take their prescribed medication and engage with any available therapy or counselling provided by Change, Grow, Live and Women Matter. And they agree to discuss with the GP the prospect of engaging with structured psychological therapy as suggested previously. In the second case study, the tenancy commenced in July 2018. Again, the ASB started straight away in the form of knocking on residents' doors, being heavily intoxicated, noise nuisance such as screaming, shouting and abusive language, banging and slamming doors, going into other residents' gas cupboards, visitors causing a nuisance, threats and common assault, and they were heavily involved with the police. The tenant was thought to have schizophrenia and also engaged in illegal substance misuse and excessive alcohol consumption. Interestingly, this was later changed to a diagnosis of mental and behavioural disorders due to multiple drug use of other psychotic substances. In this case, the housing provider attempted to address the antisocial behaviour by adopting a number of non-legal interventions, such as warning letters, verbal warnings, and a pre-legal warning letter. However, these were unsuccessful, so the housing provider was forced to take further action. In this case, they worked with the police to utilise their powers, and the tenant was served with a community protection warning and later a community protection notice. The housing provider attempted to work with the tenant and local drug and alcohol service at Action. However, the tenant would not engage despite several attempts to support them, and they continued to use illicit substances. The local mental health service, Navigo, also advised that fortunately this had not triggered a relapse in their schizophrenia on this occasion. However, they did present as unstable and volatile, but this appeared to be only when under the influence or following a come down. As a result of this, the tenant was then transferred within the mental health service to a worker who had extensive experience working with clients with substance misuse. Mental health services confirmed that the tenant appeared to have capacity in relation to decisions regarding substance misuse, and that if her schizophrenia remained stable, the plan was to discharge her. But again, despite those interventions, the behaviour continued. The tenant failed to engage with the mental health team, and they then advised that if the tenant failed to respond to any contact, care would be transferred back to the GP. The mental health team felt that the tenant was a heavy drinker and that any antisocial behaviour was solely due to her excessive alcohol and substance misuse. There is only so much a housing provider can do. In this case, after exhausting all other options, there was no other option but to seek possession due to the lack of engagement, and the result was that the tenant was evicted. You can see the difference with the previous case, that engagement with services is key to sustaining the tenancy as well as recovering from any addictions and mental health. It is extremely difficult to sustain any sort of care plan where there is a lack of engagement like this. Now we're going to have a look at what you should be doing as a housing provider when faced with a tenant who has a dual diagnosis. Hopefully this will give you some practical tips as to the steps you should be taking. The National Institute for Health and Care Excellence, also known as NICE, has recognised the need to improve services for people aged 14 and above who have been diagnosed as having coexisting severe mental health illness and substance misuse. They have issued guidance on the area with the aim of providing a range of coordinated services that address people's wider health and social care needs, as well as other issues such as employment and housing. The recommendations are for all staff who may be the first point of contact with young people and adults with coexisting severe mental illness and substance misuse who work in health, social care, public health, voluntary and community sector organisations, housing and the criminal justice system. There's quite a lot of information in this section and I have summarised this on screen, but I will also send out the document in full after the session. The first step in your role is the first contact with services. You must identify and provide support to people with dual diagnosis and aim to meet their immediate needs. This includes any physical health needs, homelessness or unstable housing. And remember, they may find it difficult to access services because they face stigma. You should be aware that the person may have a range of chronic physical health conditions. You should be aware that people's unmet needs may lead them to have a relapse or may affect their physical health. This could include social isolation, homelessness, poor or lack of stable housing, or problems obtaining their benefits. You should try to provide direct help where possible or get help from other services for any urgent physical health care, social care, housing, or other needs. You should ensure the safeguarding needs of those with a dual diagnosis are met, and you should ensure the person is referred to and followed up within secondary care, and that mental health services take the lead for the assessment and care planning. The next step is the referral to secondary care mental health services. It is useful for you to know what these services should be doing, and you can then ensure that these steps are taken when liaising with these services. So when working with these services, ensure that they do not exclude people with severe mental illness because of their substance misuse, that they do not exclude people from physical health, social care, housing, or other support services because of their dual diagnosis. They should adopt a person-centred approach to reduce any stigma and address any difficulty to access any services that people may face. And they should undertake a comprehensive assessment of the person's mental health and substance misuse needs. Once a person has been accepted into secondary care mental health services, they should be provided with a care coordinator working in mental health in the community who will act as a contact for the person. They will also identify and contact their family or carers for them, and they will help to develop a care plan with the person in line with the Department of Health's Care Programme Approach guidance, and then they will coordinate it. You should ensure that the care coordinator works with other services to address the person's social care, housing, physical and mental health needs, as well as their substance misuse problems, and provide any other support that they may need. They should involve the person in developing and reviewing the care plan to ensure that it is tailored to meet their needs. They should also involve practitioners from adult or child and adolescent mental health teams or substance misuse services, and other health and social care disciplines such as medicine, pharmacy, nursing, social work, occupational therapy and housing. So moving on to the care plan. Here, there needs to be a multi-agency approach to address physical health, social care, housing, and any other support needs. Again, it is useful to understand what needs to be included in a care plan when liaising with other services. The Person's Care Coordinator should adopt a collaborative approach with all other organisations when developing or reviewing the care plan. This includes substance misuse services, primary and secondary care, healthcare, social care, local authorities, and organisations such as housing or employment services. The care plan must include an assessment of the person's physical health, social care, and other support needs, and make provision to meet those needs. This could include personal care and hygiene, family and personal relationships, housing, learning new skills for future employment, education, and pregnancy or childcare responsibilities. The plan should also consider the suitability of the type of housing, employment, detox, rehabilitation services, or other support identified for the person in collaboration with the relevant providers. It is also important to take the person's preferences into account. It is important that the agencies and staff communicate with each other so the person is not automatically discharged from the care plan because they missed an appointment. All practitioners involved in the person's care should discuss any non-attendance. There should be multi-agency case review meetings annually or more frequently if required, based on the person's circumstances. And the care coordinator in the secondary care mental health team should usually facilitate this meeting. The meeting should be used to check the person's physical health needs, including any adverse effects from medication, social care, housing, or other support needs. Practitioners should be involved from a range of disciplines, including secondary care mental health, substance misuse, primary care, emergency care, voluntary sector, housing, adult and young people's social care. Finally, it is important that the care plan is updated in response to any changing needs or circumstances. As I've said, there's quite a lot of information in the guidance as to what is expected, so I'll send this out as a point of reference. I have also noted on screen a few further practical tips when liaising with other agencies. Firstly, information sharing is extremely important. It would be worth agreeing a protocol for information sharing between secondary care, mental health services, and substance misuse, health, social care, education, housing, voluntary and community services. It is also important to adopt a consistent approach to getting people with coexisting severe mental illness and substance misuse help from the most relevant services by sharing information on support services available, by ensuring all providers know about and can provide information on those services, and by taking responsibility as agreed in referral processes, providing timely feedback and communicating regularly about progress. Secondly, maintaining contact. All agencies should recognise that even though building a relationship with the person and seeing small improvements may take a long time, it is worth persevering. This involves showing empathy and using non-judgmental approach to listen, identify and be responsive to the person's needs and goals. Providing consistent services, for example, if possible, keeping the same member of staff as their point of contact. Staying in contact by using the person's chosen method of communication, for example, by letter, phone, text, emails, etc. I would also recommend always keeping detailed file notes of any conversations with other agencies, the tenant, etc., and keep copies of those emails. If you have spoken on the phone to other agencies, ensure that you also support this in writing with an email. All of the above will enable you to prepare a detailed Equality Act review should you need to take further action and be able to show all the steps that you have taken, that you have exhausted all other options, and that the action you are seeking is in furtherance of a legitimate aim. Once you have followed the guidelines as discussed, if the behaviour is ongoing, as a housing provider, you do have limited options. I would suggest adopting an escalatory approach, as the court would expect to see this. This might involve sending a pre-action warning letter, followed by issuing injunction proceedings, and if all else fails, by issuing possession proceedings. In any of those proceedings, it is highly likely that a medical expert will be instructed, and their findings may determine the action you take in any event. Of course, it will depend on the circumstances of the case. Finally, as it is Children's Mental Health Week, which I will come back to, I just wanted to touch on the impact of substance abuse on children. Most parents and carers who drink alcohol or use drugs do so in moderation, which doesn't present an increased risk of harm to their children. However, parents and carers who misuse substances can have chaotic, unpredictable lifestyles and may struggle to recognise and meet the children's needs. This may result in their children being at risk of harm. Living in an environment where there is substance abuse can make it more difficult for parents to provide safe and loving care, and this can lead to abuse, such as emotional or physical, or neglect. The impact of abuse and neglect on children's brains can stretch beyond childhood into adulthood. Parents and carers who misuse drugs or alcohol may turn to crime to fund their dependency, and this may mean exposing their children to unsafe adults or involving them in criminal activity. And this leads us on to Children's Mental Health Week, which is organised by Place to Be, a children's mental health charity, which provides counselling and mental health support and training in UK schools. The week aims to highlight the importance of children and young people's mental health, and they are trying to encourage more people than ever to get involved and spread the word. 1 in 6 children and young people have a diagnosable mental health problem, and many more struggle with the challenges from bullying to bereavement. This year's theme is Growing Together, and children and adults are being encouraged to consider how they have grown emotionally, recognising that trying new things can help people move beyond their comfort zones, and challenges and setbacks can help them to mature and adapt. A huge advocate in children's mental health is the Duchess of Cambridge, who will be showing her support by reading the CBeebies bedtime story on Sunday. So if, like me, your children will be watching, it will be good to see her supporting this really important cause. And if you get a chance to have a look at the Children's Mental Health Week website for any further information. There is going to be a feedback box popping up at the end of the slideshow, so if you could have a look at that, that would be really helpful. If you have any questions about the content of today's session, or you would like any further information, please drop me an email or give me a ring, and my details are on screen now. And finally, I just wanted to mention that we have a range of sessions coming up over the course of the year, and I've listed some of the topics to be covered. The next one is going to be autism in ASB cases. So keep an eye out for any invitations to these sessions if you'd like to join us. Thank you for watching, and hope you all have a good day. Bye-bye.